Welcome to the Deep Dive, where we take complex, essential information and distill it into focused insights designed to make you not just informed, but exceptionally prepared. Today, we're diving into a topic that's, well, it's no longer just important, it's absolutely fundamental for every healthcare professional. Understanding and providing truly inclusive care for persons within the LGBTQ+ community. As future nurses, your role is pivotal in ensuring that every patient receives unconditional, respectful, and affirming care free from bias or assumptions. Our deep dive today is directly from the source, a comprehensive chapter from Lewis's Medical Surgical Nursing, Assessment and Management of Clinical Problems, 12th edition. It's solid ground.
Definitely. And our mission today is really to equip you with a step-by-step understanding. We're talking foundational concepts, the significant health inequities, and crucially, the practical nursing management strategies essential for LGBTQ plus care. We'll unpack terminology, highlight key clinical applications, and, make sure you're ready to provide affirming care in pretty much any setting.
Okay, so to really provide that affirming care, we absolutely have to start with the language. Let's think of this first section as building our essential vocabulary. Because without these foundational concepts, the why and the how of inclusive nursing, they just won't resonate as deeply. Let's begin with biologic sex.
Right. Biologic sex, sometimes called sex assigned at birth, it's determined by observable physical characteristics, things like external genitalia, internal reproductive organs, and chromosomes. So typically, if someone is born with a penis, testicles, XY chromosomes, they're assigned male.
Okay.
And if they have a vagina, uterus, ovaries, XX chromosomes, they're assigned female.
That seems straightforward on the surface, but I know it's not always so clear-cut, is it?
Exactly. And that's a crucial insight right there. It immediately challenges our sort of traditional binary understanding of biology, because not everyone fits neatly into those two boxes. The term intersex describes individuals born with genitalia or chromosomal makeups that cannot be clearly categorized as solely male or female. So for you as a nurse, this means your very first assumption about a patient's sex might need to be questioned. It really sets the stage for genuinely individualized care from the get-go.
So biologic sex gives us one layer, okay, but it's really just the starting point. Because what's often much more central to a person's experience is their gender identity. This refers to a person's internal self-perceived gender. Can you elaborate on how this might differ from assigned sex?
Absolutely. So gender identity might align with the sex assigned at birth that describes someone who is cisgender.
Cisgender.
Or it might differ, which describes someone who is transgender. For example, a person assigned male at birth who identifies as female is a transgender female.
Got it.
Conversely, someone assigned female at birth who identifies as male is a transgender male. It's really important to understand transgender as an umbrella term, and we also strongly discourage using the outdated and often offensive term transsexual. Best practice, always, is just to ask a person how they identify.
That makes perfect sense. Just ask. Now let's consider gender itself. It's more of a socially constructed idea, right? Deeply influenced by cultural standards. In Western culture, we've largely viewed it as a male-female binary, but that understanding is really evolving.
It really is. And if we connect this to the bigger picture, it shows that gender isn't universally binary across all cultures. It's quite fascinating, actually. Take Indigenous American cultures, for instance, where two-spirit individuals embody both male and female spiritual essence, or the Hedruas in India, a feminine gender identity for those assigned male at birth or intersex. And in Albania, you have Bernesha women who take vows of celibacy and live as men. These examples really highlight gender as more of a spectrum, heavily influenced by cultural context.
So true. And this leads us directly to gender expression. That's how someone outwardly shows their gender, right? Through behavior, mannerisms, interests, appearance, like clothing or hairstyle. And we're also seeing a growing recognition that gender itself can be fluid.
Right. You hear terms like non-binary, gender fluid, or gender queer. These describe individuals who don't identify as completely one gender or the other. And it's also important for you as nurses to differentiate this from cross-dressing.
Okay, how so?
Well, cross-dressing typically describes men, often heterosexual men, who wear women's clothing sometimes for pleasure or performance, but they don't necessarily identify as female full-time. These are distinct concepts, and understanding that difference prevents misgendering or making, inappropriate assumptions.
That's a really vital distinction for our listeners. Okay, next up, gender dysphoria versus gender nonconformity. How do these differ, and why is this distinction so important for nursing students?
This is a critical area. Gender dysphoria is a clinical diagnosis. It describes the significant distress or impairment a person experiences because of a marked conflict between their gender identity and the sex they were assigned at birth. The diagnostic criteria, which your Lewis textbook outlines in Table 6.1, focus on the sustained incongruence and the associated distress it causes in social or occupational functioning.
So it's about the distress.
Exactly. The crucial insight for nurses is that gender nonconformity, which is simply differing from cultural norms in identity, role, or expression, is not a mental health disorder. It's about respecting individual variation, not pathologizing it.
That's a key takeaway. Okay, finally, for our foundational concepts, let's cover sexual orientation. This is about who someone is attracted to, sexually or romantically. It involves three aspects: behavior, attraction, and identity. And I guess these aren't always perfectly aligned.
That's right. They can be independent. And remember, a person's gender identity, like being transgender, is separate from their sexual orientation.
Ah, that's a common misconception, isn't
It
it?
is. Transgender people can be gay, lesbian, bisexual, or heterosexual, just like cisgender people. Being transgender doesn't automatically define who someone is attracted to. And language matters here, too. We generally prefer terms like gay man or lesbian over homosexual, mostly because of its historical stigma. Bisexual, or bi, is used for attraction to more than one gender.
Okay. And beyond these core terms, the chapter also introduces others you might encounter. Things like asexual, maybe.
Yes, exactly. Asexual describes someone who doesn't experience a sexual attraction. Polyamorous refers to those in consensual, multiple romantic relationships. And for individuals still exploring their identity, they might use the term questioning. Getting comfortable with this terminology is really the first step in providing patient-centered care. It shows respect right away.
Absolutely. So now we've built our vocabulary, let's dive into why this all matters by looking at LGBTQ plus health inequities and disparities. This isn't just about definitions, it's about real, often devastating health outcomes that directly impact the patients you'll be caring for.
A key insight here is the minority stress model. This model explains that the health disparities faced by the LGBTQ plus community aren't just random. They largely stem from chronic stressors. Think stigma, discrimination, a hostile cultural environment. It often leads to a lifetime of harassment and victimization.
And the historical context is pretty stark, too.
Oh, absolutely. Consider this. Homosexuality was classified as a mental illness by the American Psychiatric Association until 1973. That institutionalized prejudice left a profound, lasting impact on the community's trust in healthcare providers.
That historical context is so vital for nurses to grasp. And beyond individual experiences, there are significant societal and legal barriers that still perpetuate discrimination. Cultural beliefs, religious views, institutionalized inequalities. Unfortunately, these continue to create challenges within healthcare settings.
They really do. It's shocking when you look at the stats. Surveys found 56% of LGBT persons and a staggering 70% of transgender persons reported experiencing discrimination from healthcare providers.
70%. What?
It's a huge barrier. And this discrimination also directly impacts socioeconomic status. Our source, Lewis, highlights that 22% of LGBT persons and 29% of transgender persons live in poverty in the U.S., compared to about 16% of cisgender straight people.
And poverty means less access to care.
Exactly. It limits access to health insurance, the ability to engage in preventative wellness behaviors. It just compounds health issues. While the legalization of same-sex marriage in 2015 was a landmark legal step, it really underscored how critical those legal rights like hospital visitation, healthcare decision-making, spousal insurance are for basic healthcare access and autonomy.
So for nursing students listening, what are the most critical, specific health disparities and risk factors they need to be aware of when caring for LGBTQ plus patients?
Okay, a major area is substance use and mental health. Rates of alcohol and tobacco use are nearly twice as high among LGBTQ plus persons compared to heterosexuals. And mental health challenges are more prevalent too. Nearly 1 in 3 LGBT adults and about 40% of transgender persons experience mental health disorders, compared to roughly 1 in 5 heterosexuals. You're more likely to see these issues presenting in your patients.
And it becomes even more concerning when we look specifically at LGBTQ plus youth. The statistics are just heartbreaking.
They really are. Over 70% reported feeling down or hopeless in the past year. Nearly 40% considered suicide.
40%.
And for transgender and non-binary youth, that number jumps to over 50% who seriously considered suicide in the past year. As a nurse, you're on the front lines. Understanding these risks is paramount for early intervention and support.
Absolutely critical. What about other areas like violence?
Another critical area is violence and victimization. LGBTQ plus individuals experience higher rates of hate crimes and intimate partner violence, and transgender women of color are disproportionately affected, tragically accounting for nearly 40% of LGBTQ plus related homicides. Nurses need to be aware of these safety risks and, screen appropriately and sensitively.
Okay. In terms of cancers, are there specific considerations nurses should keep in mind?
Yes, lesbians may have a higher incidence of breast cancer, which seems linked to factors like higher rates of tobacco use, obesity, and nulliparity, meaning never having given birth. Men who have sex with men, MSM, especially those living with HIV, have nearly twice the rate of anal cancer from HPV compared to other men. And higher lung cancer rates are seen across the community, often tied back to that higher prevalence of tobacco use.
And let's not forget obesity. That's mentioned too.
Right. Lesbian and bisexual women tend to have higher rates than heterosexual women, which increases their risk for chronic conditions like diabetes, heart disease, hypertension, and osteoarthritis. It's a significant comorbidity factor.
Okay. And then there's HIV and STIs.
Yes, disproportionately higher rates, particularly among MSM and transgender women. It's important to know that the majority of new HIV infections in the U.S. still occur among MSM, and the lifetime risk for Black MSM is estimated to be as high as 1 in 2. These are critical areas for targeted prevention, education, and screening that you as a nurse will absolutely need to address.
Which really highlights a systemic issue, doesn't it?
Yeah.
Especially when we consider structural barriers in healthcare education. The source points out that health professionals often receive less than 5 hours of training in LGBTQ plus culturally appropriate care. How does this directly impact patient care?
Oh, it's a huge problem. This lack of foundational knowledge directly contributes to the discrimination and health disparities we've just been talking about. It means nurses might not know the right words to use, might not understand the unique risk factors, or just might not feel equipped to provide sensitive, affirming care. That creates even more barriers for patients trying to access care.
It really underscores the need for education like this deep dive. And finally, a crucial, often overlooked area, gerontologic considerations. What unique challenges do older LGBTQ plus adults face?
This is so important. Many older LGBTQ plus adults don't have children to support them as they age. They often rely heavily on partners or friends, their chosen family, for caregiving, over half, according to the text. This generation also lived through the height of the HIV/AIDS epidemic, leading to higher rates of social isolation due to losing so many friends and partners.
That's profound.
It is. And what's particularly poignant for nurses, and something you need to be aware of, is the documented fear many older LGBTQ plus adults have of going back in the closet when they enter long-term care facilities. They worry about negative reactions from other residents or even staff. Recognizing this vulnerability allows you, as a nurse, to proactively create truly safe and affirming spaces for them.
That's a powerful reminder of how deep these social factors run. But it also leads us nicely to the crucial next step. What can we do? Establishing inclusive environments in healthcare. The Joint Commission actually has guidelines for this now, right? As part of the accreditation process.
Yes, and these guidelines are foundational. They include things like hospitals posting clear non-discrimination visitation policies, providing unisex or single-stall bathrooms, which benefits many people, not just LGBTQ plus individuals, and importantly, collecting sexual orientation and gender identity information, SOGI data, on patient intake forms. For you as nurses, these are the basic structural supports you can expect to find or frankly advocate for if they aren't present.
So how do we translate that into creating a genuinely welcoming environment in practice? Our source, Lewis, gives several excellent actionable strategies. Think about the common areas in a clinic or hospital unit. Displaying an inclusive patient bill of rights, maybe using symbols like the rainbow flag discreetly, having brochures or posters that show diverse couples and families.
Exactly. Ensuring there are all-gender restrooms available, providing LGBTQ plus a-specific health literature, and staff can also incorporate visual cues. Small things like rainbow pins or stickers on ID badges can signal a safe space and indicate you're an ally. This helps establish that welcoming feeling even before you start talking.
Good point. Then when it comes to the actual health history and intake process, there are some really critical steps.
Absolutely. Number 1, always ask for a patient's preferred name, their gender identity, and their pronouns.
That seems like such a basic sign of respect, but it's so important. And I know for transgender persons, their legal name might be what's called a dead name they no longer use.
Precisely. So explicitly asking something like, is there a name you would like for us to use for you while you are here, is essential. Ask every patient, make it routine.
And when asking about gender identity.
The recommended approach is the two-step question. First, what was your sex assigned at birth? And then, what is your current gender? Always follow up with, do you have any preferred pronouns? It's simple, direct, and respectful.
And if you make a mistake, if you accidentally use the wrong name or pronoun.
Just apologize immediately and sincerely, correct yourself, and move on. Don't make a big deal out of it, just fix it. It shows you're trying and you care.
Okay. What about other inclusive communication strategies?
Yeah, the source lists several good ones in Table 6.4, like avoid using gendered terms like sir or ma'am until you know the patient's identity and pronouns. Use their preferred first and last name instead. Refer to the patient if you're unsure. And use the term transition to describe the process of gender affirmation.
And terms to avoid.
Definitely avoid sexual preference. It implies choice where orientation often doesn't feel like one. Avoid transgendered, the ed is unnecessary. Don't refer to someone as a transgender. And steer clear of outdated or offensive terms like pre-op or post-op sex change. These are listed in the table as well. And remember, always focus your questions on what's relevant to the patient's current reason for seeking care. Don't pry unnecessarily.
Excellent advice for ensuring patient comfort and trust. Okay, moving to the social history. How should we approach questions about relationships or living situations?
Use gender-neutral terms. Ask about their partner or spouse instead of assuming a husband or wife based on their appearance or gender identity.
That naturally leads us to a really crucial point the book makes about family of choice.
Indeed. This is so important. For many LGBTQ plus persons, especially those who might have experienced estrangement or lack of support from their family of origin, their family of choice, which might include friends, partners, selected relatives who are supportive, often forms their primary support system.
So what's the critical nursing implication here, especially thinking about legal protections and decision-making?
This is where advanced directives become absolutely paramount. The GV case study in box 6.1 in Lewis illustrates this perfectly. You have a 64-year-old woman. She has a life partner of 35 years named as her healthcare proxy.
Okay.
But then her brother, a member of her family of origin, disputes this during a critical illness. This creates huge legal and ethical dilemmas right when decisions need to be made.
A nightmare scenario.
Totally. Without clear legal protection, like a durable power of attorney for healthcare, the family of origin, who might not understand or respect the patient's wishes or relationship, could potentially gain decision-making power over the chosen family. So nurses must ensure patients understand the importance of advanced directives and have access to creating them. This is especially vital for LGBTQ plus patients to protect their end-of-life choices and ensure their chosen family is recognized.
That case study really drives home the importance of proactive nursing advocacy. Okay, next. When taking a sexual and reproductive health history, what's the best approach?
The key is non-judgmental language and focusing on relevance. Be comfortable asking the necessary questions, but frame them based on anatomy and behavior, not assumptions about identity or orientation. Always ask about pregnancy prevention needs. Don't assume based on gender identity or partner status. Ask about family planning desires, STI risk factors. Clarify that LGBTQ plus persons may have children or want to become parents, so these questions are still very relevant.
Got it. Now, shifting to preventive health. Beyond the standard screenings everyone needs, what specific initiatives and screenings should nurses prioritize for the LGBTQ plus community, based on the Lewis text?
Okay, box 6.2 in the chapter highlights some key initiatives. Things like supportive social services to reduce suicide risk, strong anti-bullying policies in schools and communities, and obviously essential health professional training like what we're doing right now. Specific screenings include hepatitis A and B vaccinations for MSM because they have higher rates. HCV or Hep C antibody screening is also recommended for at-risk MSM and transgender women.
And for HIV prevention.
Education is key, specifically about pre-exposure prophylaxis, a daily medication to prevent HIV infection, and PE post-exposure prophylaxis medication taken after a potential exposure. You need to be ready to discuss these options.
What about cancer screenings?
Breast and cervical cancer screenings remain important, particularly being mindful of lesbian and bisexual women who might have those higher risk factors we mentioned, like tobacco use or nulliparity. And here's a really crucial reminder for all nurses, something the book emphasizes. Never assume a transgender patient has undergone gender-affirming surgery.
That's a huge point.
It is. A transgender woman assigned male at birth may still have a prostate and needs prostate cancer screening according to guidelines. A transgender man assigned female at birth may still have a cervix and uterus and needs cervical cancer screening.
So assessment drives the screening.
Exactly. Your assessment of their anatomy and risk factors guides your screening recommendations, not assumptions based on their gender identity or expression.
Okay. And one more risk factor, tobacco use.
Yes, significantly higher rates, like 2 to 3 times higher in LGBTQ plus persons compared to the general population. So, screening for tobacco use and consistently offering cessation support and resources should absolutely be routine practice for all patients, but especially important given the disparity here.
Great points. Finally, let's explore the specifics of gender-affirming care. This includes both hormone therapy and surgical interventions. Let's start with gender-affirming hormone therapy, or GAHT. What's the main goal here?
The primary goal of GAHT is to help align a person's physical attributes and hormones with their affirmed gender. It essentially aims to induce the secondary sex characteristics associated with that gender, kind of mirroring the changes seen in puberty.
Okay, so let's break that down. For masculinizing hormone therapy, which typically uses testosterone, what are the key effects nurses should anticipate and manage?
All right, with testosterone, you'll typically see increased muscle mass, facial and body hair growth, a deepening of the voice, and usually cessation of menstrual periods, or amenorrhea. There can also be clitoral enlargement. From a nursing perspective, key considerations include teaching proper self-injection techniques and site rotation if they're using injectable T. If it's topical, teaching about avoiding skin-to-skin transfer to others is vital.
Are there risks or contraindications?
Yes, contraindications include pregnancy, unstable coronary artery disease, and untreated polycythemia that's an abnormally high red blood cell count. Sometimes consults with oncology or cardiology are needed. And importantly, testosterone is not a reliable form of birth control, so contraception counseling is still needed if relevant based on anatomy and sexual activity. We also monitor things like hemoglobin and hematocrit and look out for side effects like oily skin or acne or vaginal dryness.
Okay. And for feminizing hormone therapy, usually involving estradiol plus an anti-androgen agent, what are the primary changes in nursing considerations?
With feminizing therapy, you anticipate effects like breast growth, some redistribution of body fat often from the abdomen to the hips and thighs, softer skin, decreased libido, decreased testicular size, and potentially slowing of male pattern hair loss. Key nursing considerations here include the increased risk of venous thromboembolic events, or VTEs, blood clots. This is especially important if using oral estradiol.
So a history of VTE would be a major contraindication.
Absolutely. Other contraindications include estrogen-sensitive cancers, like certain breast cancers, and severe or end-stage liver disease. If injections are used, teaching technique is important, just like with testosterone. If they're using an anti-androgen like spironolactone, you need to monitor their potassium levels because it can cause hyperkalemia. Finasteride or dutasteride are other anti-androgen options.
Any other potential side effects to watch for?
Sometimes patients can develop prolactinomas, which are pituitary tumors, so symptoms like galactorrhea, milky nipple discharge, vision changes, or headaches warrant investigation. Also, migraines can sometimes worsen with estrogen therapy.
So general nursing management for anyone on GAHT.
Always assess their desires regarding future fertility before starting therapy, if possible. Provide resources for sperm banking or egg embryo freezing. Counsel thoroughly on expected effects, potential side effects, and the importance of adherence. And critically, unless there's the specific contraindication related to their acute condition, hormone therapy should generally be continued during hospitalization to avoid withdrawal symptoms or distress.
Makes sense. Now, beyond hormones, there are also non-surgical gender-affirming interventions. What are some examples, and what should nurses be assessing for?
These include practices like chest binding for transgender men, or individuals assigned female at birth who want a flatter chest appearance, or tucking for transgender women, or those assigned male at birth wanting a flatter groin contour.
And the nursing role?
Primarily assessment. You need to check the skin under binders, or where tucking occurs, for signs of irritation, breakdown, infections, or rashes. Safe practices should be discussed. Other non-surgical things include cosmetic fillers like silicone for facial feminization, but it's crucial patients see qualified, licensed professionals for this, as illicit silicone injections are incredibly dangerous. There's also vocal therapy with a speech pathologist, or even vocal surgery to help feminize the voice pitch and resonance.
Okay. And finally, we come to gender-affirming surgery, GAS. What's the most important thing for our listeners to understand about these procedures?
I think the most vital thing is that not all transgender persons choose or desire surgery. It's highly individual. And the specific procedures vary enormously based on the patient's personal goals, their health status, and resources. It's not a one-size-fits-all path.
So the nursing focus is on comprehensive management for those who do pursue surgery.
Exactly. Preoperative assessment is key. Requirements typically include having persistent, well-documented gender dysphoria, the capacity for informed consent, being the age of majority, and having any significant medical or mental health conditions reasonably well controlled. Collaboration between the surgical team, the hormone provider, and mental health professionals is absolutely essential throughout this process.
Got it. And what are the key nursing responsibilities postoperatively, both in the hospital and after discharge?
In the acute care setting right after surgery, your standard excellent postoperative care applies monitoring vital signs, managing pain, preventing complications like VTEs. Specifics depend on the surgery, but you'll often be assessing surgical drains for the amount and type of drainage, inspecting supportive dressings like chest binders after top surgery for any excessive bleeding or constriction, and prioritizing effective pain management.
And for ambulatory care, discharge, teaching, and follow-up.
Education is huge. Teach patients the signs and symptoms of potential complications like seromas, fluid collections, hematomas, blood collections, and infection redness, warmth, increased pain, discharge. Instruct them on activity restrictions. For example, after chest surgery, they'll likely have limited range of motion in their arms for several weeks, needing to avoid heavy lifting or reaching overhead. You might advise on modifications needed for home or work during recovery.
Okay. And for long-term screening after surgery, what's the critical reminder?
Even after chest masculinization surgery or top surgery, there's still a small amount of breast tissue remaining, so the theoretical risk of breast cancer isn't zero. Patients should still be counseled on awareness and appropriate screening based on risk. And for transgender women who have undergone feminizing breast augmentation, current guidelines generally recommend starting breast cancer screening at age 50 if they've been on feminizing hormone therapy for at least 5 years. Again, it's about ongoing, tailored care based on their specific situation.
That was truly a deep dive.
Yeah.
Wow, we've unpacked so much. The importance of accurate terminology, explored the profound impact of health inequities on the LGBTQ plus community, and discussed practical, affirming nursing interventions, from creating inclusive environments and taking sensitive histories to managing gender-affirming therapies and surgeries. It's a lot, but so important.
It really is. And, as healthcare professionals, your role extends far beyond the clinical procedures. It's really about being powerful advocates for dignity, for understanding. So maybe a final thought to consider. How can you personally contribute to dismantling some of these barriers we talked about? How can you foster a truly equitable healthcare experience for every single patient, regardless of their identity? What's one small change you can implement, maybe even starting today or tomorrow in clinicals, to make your practice more inclusive?
That's a great question to leave our listeners with. Thank you so much for taking this deep dive with us today. Remember, this knowledge is a powerful tool for compassionate, competent, and truly excellent nursing practice, ensuring you're ready to serve all your patients well.